10 key points about viral meningitis. Etiology of viral meningitis. Viral meningitis is caused by a variety of viruses, with enteroviruses being the most common culprits. Other significant viral pathogens include herpesviruses, such as herpes simplex virus, and arboviruses like West Nile virus and Eastern equine encephalitis virus. The specific virus involved can often be linked to the patient's exposure history and the time of year, as certain viruses are more prevalent during specific seasons. Understanding the etiology helps in identifying high-risk populations and implementing preventive measures. For instance, enteroviruses are more common in children and during the summer and fall months. Epidemiology. Viral meningitis affects individuals worldwide, with varying incidence rates depending on the region and the specific virus. In the United States, enteroviruses are responsible for the majority of viral meningitis cases, particularly in children. Herpesviruses, including herpes simplex virus, are also significant causes, especially in adults and immunocompromised individuals. Pathophysiology. Viruses enter the central nervous system through various routes, including hematogenous spread from a primary infection site or direct invasion from adjacent tissues. Once in the central nervous system, the virus replicates and triggers an inflammatory response, leading to meningeal irritation and increased blood-brain barrier permeability. This results in the characteristic symptoms of meningitis, such as headache, fever, and stiff neck. The pathophysiological process is less severe compared to bacterial meningitis, with fewer complications and less tissue damage. Clinical features. Patients with viral meningitis typically present with fever, headache, stiff neck, and sometimes nausea and vomiting. Unlike bacterial meningitis, the symptoms are generally milder and altered mental status and seizures are less common. The onset is often gradual, and the course is usually self-limiting. It is important to note that while the symptoms may be less severe, they can still be debilitating and require medical attention to rule out more serious conditions. Risk factors. A thorough history helps in identifying risk factors associated with specific viral pathogens. For example, exposure to mosquitoes can increase the risk of arboviral meningitis, while immunocompromised patients are more susceptible to herpes viral infections. Recent travel history and seasonal exposure can also provide clues to the causative virus. Understanding these risk factors guides the selection of diagnostic tests and aids in the early identification of potential complications. Physical examination. The physical examination in viral meningitis may reveal signs of meningeal irritation, such as Brudzinski sign and Kernig sign, although these are typically less pronounced than in bacterial meningitis. Focal neurologic deficits and signs of increased intracranial pressure are rare but should be carefully evaluated. A thorough examination also includes assessing for skin rashes or other systemic signs that may indicate a specific viral infection. Diagnosis. The diagnosis of viral meningitis is primarily based on CSF analysis. Cerebrospinal fluid findings typically include normal or slightly elevated opening pressure, a lymphocytic predominance in the white blood cell count, less than 300 cells per cubic millimeter, normal or slightly elevated protein levels, and normal glucose levels. Polymerase chain reaction and viral cultures can be used to identify the specific viral pathogen, although these tests may take longer to yield results. In addition to CSF analysis, serum polymerase chain reaction and viral antigen tests can aid in diagnosis, especially when CSF results are inconclusive. Laboratory testing. Laboratory testing beyond CSF analysis includes serum polymerase chain reaction, viral cultures, and antigen detection tests. These tests can help in identifying the specific virus and guiding treatment, especially in cases where the CSF results are not definitive. For example, herpes simplex virus polymerase chain reaction is highly sensitive and specific for diagnosing herpes simplex encephalitis, a condition that requires prompt antiviral therapy. Serum procalcitonin and C-reactive protein levels can also be used as adjuncts to differentiate between viral and bacterial meningitis, although they are not definitive. CSF analysis of bacterial meningitis. The CSF analysis for bacterial and viral meningitis reveals distinct differences that are necessary for diagnosis. In bacterial meningitis, CSF analysis typically shows elevated opening pressure, a high white blood cell count, greater than 1,000 per cubic millimeter, with a neutrophilic predominance, elevated protein levels greater than 200 milligrams per deciliter, and decreased glucose levels, less than 40 milligrams per deciliter, or a CSF to blood glucose ratio less than 0.4. Gram stain and culture are positive in a significant proportion of cases before antibiotic treatment, and rapid latex agglutination tests and PCR can aid in identifying bacterial antigens and organisms. CSF analysis of viral meningitis. In contrast, viral meningitis presents with different CSF findings. The opening pressure is usually normal or only slightly elevated, and the white blood cell count is lower, less than 300 per cubic millimeter, with a lymphocytic predominance. Protein levels are normal or slightly elevated, and glucose levels remain normal. While PCR and viral cultures can be used to identify the specific viral pathogen, these tests often take longer to yield results. These differences in CSF analysis are key to distinguishing between bacterial and viral meningitis, guiding the appropriate treatment and management strategies. Treatment and antiviral therapy. The treatment of viral meningitis is primarily supportive, focusing on hydration, rest, and antipyretics to manage symptoms. Antiviral therapy may be indicated for specific viral causes, such as herpes simplex virus encephalitis, where acyclovir is the treatment of choice. For most cases of viral meningitis, however, antiviral therapy is not necessary, and the condition resolves on its own within a week to 10 days. Supportive care includes managing seizures with anticonvulsants, avoiding hypotonic fluids, and monitoring serum sodium levels to prevent complications like syndrome of inappropriate antidiuretic hormone or cerebral salt wasting. Management of complications and adjunctive care. While viral meningitis is generally less severe, it can still lead to complications such as seizures, encephalitis, or, in rare cases, long-term neurologic deficits. Close monitoring for these complications is essential. Patients should be evaluated for signs of increased intracranial pressure, although this is rare in viral meningitis. In cases where complications arise, admission to the intensive care unit may be necessary to ensure proper care and monitoring. Adjunctive care includes managing fever, providing pain relief, and ensuring adequate hydration. In some cases, corticosteroids may be considered to reduce inflammation, although their use is not routine.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.